Today we're going to talk about risk-based assessments in prostate cancer diagnosis. Here are my disclosures. Let's start with a case study. We have a 57-year-old physician, has a family history of prostate cancer. His father died at a young age. His PSA is 5.6, his DRE is normal, and his glandular volume is 61 ml. He comes to see you rather than the urologist, and he asks you if he needs a trus biopsy. So, would you say, get a trus biopsy because this is the standard of care? Would you say, no, there's too much uncertainty with the trus biopsy approach? Would you say that you need more information? And then what more information do you need? Would you say get an MRI scan and then decide? Or would you say, I really don't know anything about this condition, I'm the wrong person to ask? Interesting dilemma. The problem with the current pathway is that there is no imaging before the biopsy. Clearly, the systematic trus biopsy is image guided, but it's not guided to a tumor. It is actually guided to the prostate gland via ultrasound. And radiologists don't figure in the current pathway. However, as radiologists, we can make some strong claims regarding the use of MRI in suspected or newly diagnosed patients. So we can stand up on some tall shoulders and say that MRI has the performance characteristics to help manage patients. Help manage patients with suspected or proven cancers. And not only do the UK NICE guidelines say this, the EAU guidelines from Europe state this, and even the NCCN guidelines on prostate cancer also state this. You should also be aware that success in being able to rule in and rule out is dependent on a number of factors. That is, you have to use the multiparametric approach. Image quality is certainly key. The reading system that you use is obviously important, and the expertise of the reporter, it also matters. Now, we all have to be aware that cancer detection is really dependent on where the cancer is located. Peripheral zone, transition zone. It depends on the tumor volume and on the aggressiveness of the underlying tumor. And the clinical utility, which is quite different to detection ability, is an interdependent function between the prevalence of the disease and the performance of the disease. And we will talk about this in a little bit more detail later. So, as you begin your urological discussions about who should get an MRI, the first thing you should agree is that you should only do MRI in people who are likely to benefit, taking into account comorbidities and life expectancy. Now, what does that mean in practice? Well, if you look at the NCCN guidelines, which were released recently, you will see that it is clearly stated that multiparametric MRI may be helpful to identify regions missed by prior biopsies, and so should be considered in selected cases with at least one negative biopsy. So here's a patient group that you should be able to agree with your urologists that a negative biopsy group is a group that you can accept as being one of the indications. The other interesting thing it says, for high-risk men with negative biopsies. High-risk men. So who are these high-risk men? Well, we'll come back in a second. So for high-risk men with prior negative biopsies, consideration should be given to the use of MRI, followed by lesion targeting to maximize detection of higher grade, higher risk disease and limit the detection of lower risk disease. And in fact, this gets a recommendation of 2A, which is the first category below the top category, which is a category 1. Furthermore, the NCCN guidelines also state that MRI is not routinely recommended prior to the first biopsy, but emerging data suggests that when used in this way and targeting is performed with an MRI fusion biopsy, it may increase the detection of clinically significant disease and higher risk disease while lowering the detection of low risk disease. So it doesn't recommend using it prior to the first biopsy, but if you do use it, there are benefits that you may gain. And again, this is quite an interesting caveat. The interesting thing here in both recommendations is the use of an appropriate targeted biopsy, and it recommends MRI ultrasound fusion in this regard. So here we are. This is the same patient, the general practitioner. So what would you recommend? An MRI, a trust biopsy? There's too much uncertainty, or is it not your problem? Well, my view is that we need more information. There are several methods of assessing what the a priori risk of somebody having a clinically significant tumor are, and one of these methods is to use a risk calculator. Now, there are several risk calculators available, and in Europe, the risk calculator is called the European Risk Calculator or the Rotterdam Risk Calculator. In North America, there is the Sunnybrook Calculator and the Prostate Cancer Prevention Trial Risk Calculator. And this is the one that you should use if you're in America, because this is enriched with a black population. The European calculator should be used in predominantly white people. Now, you'll notice that there are recommendations for biopsy and recommendations for not doing biopsy. So, the recommendation for doing a biopsy in the European calculator comes out when the risk is greater than 20%, and in the North American calculators when it's greater than 30%. So, if we take this same patient, we plug him into the risk calculator, the Rotterdam risk calculator, and you do it on your Android phone, you can see that the detectable cancer risk is 10%, the significant cancer risk is 2%. And if you do it on the website, you can see the corresponding figure is 16%. The chance of having a positive biopsy is 16%. The chance of having a high-grade cancer or having advanced disease is 3%. Okay, so how do you use these values? Remember, the cutoff point for a biopsy is 20%. The background risk of significant cancer is 3%. So your particular patient actually falls below the risk for the background risk, and in fact is not high risk at all. He probably doesn't need an MRI, and he probably doesn't need a biopsy. So what would your advice be? Would you do an ultrasound trust biopsy? Would you say this guy is borderline, so maybe I'll do an MRI anyway? Would you say actually he needs nothing, no MRI, no biopsy, or would you just stand and say, really, I'm not in a position to be able to advise? Well, both B and C could be positions that one could take, and this is clearly something that needs to be decided by a urologist working with a radiologist about who undergoes MRI. Okay, so this guy was a physician, and so we were pushed into doing an MRI for this guy. And you know what? We found a small lesion. We have a small focal hyperintense lesion in the left apex between the transition zone and the peripheral zone. This is an anterior fibromuscular stromal tumor, and this is a Pyrites 4 out of 5 lesion. Now we have a conundrum. What do we do about such a small lesion? Now clearly he needs a biopsy. Well, the question is, what sort of biopsy should he have? Well, we could do a standard truss biopsy, but we know we will miss it. It's systematic. We will miss the lesion. We could do some targeted biopsies, and that is to say, we could acquire 3 to 5 cores. That would improve risk stratification. That would increase the diagnosis of clinically significant disease. That would reduce the diagnosis of indolent disease, and he would only get 2, 3, 4 needles. And this is something that the NCCN advises. On the other hand, it's possible to get the diagnosis using a saturation biopsy technique or a template biopsy technique, and saturation biopsies can be done transrectally or transperineally, and template biopsies are generally done transperineally. The interesting thing is that although these are all increasingly systematic, the number of cores increases dramatically. However, you would improve risk stratification, no doubt about it. You would increase the diagnosis of clinically significant disease. However, the diagnosis of indolent disease would increase dramatically also. So you may not want to use these approaches. Okay, so here we are. This patient. So which is the best biopsy strategy for this particular patient? Would you do truss biopsies because it's the standard of care? Would you do targeted biopsies? Or would you do a truss plus a target just to be sure? Would you do a saturation biopsy with 20 needles transrectally? Would you do a saturation biopsy transperineally? Or would you do template biopsies? Most urologists would recommend doing this. They would say we would do a truss and a targeted biopsy just to be sure. In other words, if you had a lesion like this, a large anterior tumor, you target the lesion using ultrasound, put a couple of cores through this lesion, but you would do standard truss biopsies at the back of the gland just to be sure. Now, that's what the pathway looks like now. So you've made your diagnosis. Here's your systematic truss plus targeted biopsies for lesions, and you know that you would get these benefits. You would have greater precision in diagnosing tumor grade and volume, in other words, risk stratification, and you would increase the rates of detection of clinically significant disease. The problem with this approach is overdiagnosis. How much overdiagnosis occurs with this approach? Well, it depends on your cohort of patients. So if you have a repeat biopsy cohort, 18 combined biopsies would be needed to detect one additional significant cancer. 18 biopsies to detect one additional significant cancer, but you would overdiagnose 3.7 low-risk cancers. In a first biopsy cohort, you would have to do 14.8 combined biopsies to detect one additional significant cancer, but you would end up overdiagnosing 2.3 low-risk cancers. So if you wanted to be sure, you know that you have to do a lot of biopsies to detect that additional significant cancer, but you would also overdiagnose quite a number of patients who don't need a diagnosis. This clearly requires a discussion between you and your urologist about what is the appropriate strategy for patients. So in this particular patient, what did we do? We did a targeted biopsy alone because the peripheral zone is completely normal, and we know that the negative predictive value at the sector level is more than 90 or 95%, and the peripheral zone can be followed in the future. So the important message from this is that we recommend the availability and the use of methods that minimize overdiagnosis of any insignificant disease and improves the risk stratification of patients. In other words, you need to be tooling up. So this is the kind of example that I want to emphasize. So here is a patient with a small tumor anterior. We know we're going to miss this if we use a standard truss biopsy approach. In this particular case, an in-bore biopsy, targeted biopsy, was performed with MRI guidance. On the other hand, if you look at this patient over here, we can see that there's a diffuse lesion in the left peripheral zone. This could probably be sampled by a standard truss biopsy approach with 6 needles through that area. You will get the diagnosis, and in this particular case it was Gleason 3+3 disease. So the MRI for diffuse disease can have a truss biopsy, for a targeted biopsy, for something that is focal. And if you were to undertake this strategy, you would reduce the diagnosis of indolent disease, and you would perform fewer targeted biopsies per patient. That would be the benefit. Now, the question that arises is, what do we do with patients who have a negative MRI? In other words, how many patients with a negative MRI in fact harbor cancer? This is quite a difficult number to come up with. So here's a study, the largest study to date, 830 patients with a negative MRI with no target, underwent no biopsy procedures. 830 patients. There were high-risk cancers missed within this group. How many were there? There were 18. So 18 out of 830 patients. The interesting thing was the majority of these were organ confined when detected, and the majority of these were detected within 1 year of follow-up. So what we're saying is, if you have a negative MRI, you do not discharge these patients, because we know that there are some significant cancers in this group. They need to be followed up, reassessed, and then they need to re-enter the diagnostic pathway if there is persistent clinical suspicion for disease within the prostate gland. So here is a patient who is a golf buddy of your radiology manager. He presents with perineal pain. He has a PSA of 4.8. His glandular volume is 68 ml. If you look at his risk calculator, you can see he has a 7% chance of having any cancer, but only a 1% chance of a clinically significant cancer. So would you advise a truss biopsy, because this is the standard of care? Would you advise an MRI and then decide? Would you say, this man does not need an MRI, he does not need a biopsy? Would you say, I don't even play golf, why are you asking me this question? Okay, now remember, he is your radiology manager's buddy. So my arm was twisted. We decided to do an MRI, and we found a lesion, a small lesion, the left apex, 6 to 7 ml. That lesion is very subtle. There it is on the T2 sequence, slightly hyperintense, ADC is a little bit low. That should be called a PIRADS 2 lesion. The mistake I made was calling it a Peyer's 4 lesion. Now, this prompted action. The action should have been a targeted biopsy to that area, or, in fact, nothing. We should have left this guy alone. So what would you do with this particular patient? Would you do a truss biopsy? Would you do a targeted biopsy? Would you do a truss plus targeted biopsy? Or would you do a template biopsy? Or would you just say, actually, this guy doesn't need a biopsy at all? So he underwent a systematic biopsy plus 4 targeted course. No cancer was detected. But, Houston, we have a problem. So this is an intraprostatic abscess. He's had 5 hospital admissions. He's had 5 courses of antibiotics. We have ruined his Christmas. Could we have avoided this situation? The answer to that is yes, probably. So, if you look at this study that's just been published, 122 patients with a negative truss biopsy, but a suspicion for a cancer on a multiparametric MRI, in other words, Peyer's 3, 4, or 5. Interestingly, if you had used the risk-based approach, which I have just suggested, would have avoided an MRI in half of the patients, would have avoided overdiagnosis in 2 of 8 patients with low-grade disease, but would have underdiagnosed 3 of 31 patients with high-grade cancer. In other words, there seems to be some data building for the use of a risk calculator before the use of an MRI. And I guess we watch this space for future data to emerge. Okay, let's see how much you've learned. Let's do a couple of cases. So here's a 58-year-old. You can see his PSA has gone up in about 6 months. His DRE is normal. His glandular volume is 30. Now, his detectable cancer risk is 31%. His significant cancer risk is 8%. So, he should get a biopsy. Would you do an MRI before the biopsy? Answer yes or no. Well, we decided to do MRI before biopsy, and this is what we found. So you can see in the peripheral zone there are these areas of linear band-like load signal change which shows diffuse enhancement. No abnormality on the high p-value image, nothing on the ADC map. So, what is this? This is inflammation. This is a Peyer's 2 lesion. This is inflammation. There is atrophy. There is irregular hyperemia. There is no mass. This patient, in fact, does not require a biopsy. And so, what was the benefit for the patient and the pathway of performing this MRI? 1. You provided an alternate diagnosis. 2. If a biopsy is done, and the recommendation on the risk calculator is that it should be done, then MRI provides a target. Number 3. There's the potential here to reduce overdiagnosis and potentially overtreatment. So in this particular case, we recommended no biopsy. Let's do another patient. Here's a 54-year-old with a PSA of 5.4. He has a positive family history. His DRE is positive, but on the right side. His glandular volume is 56.5 ml. His detectable cancer risk is 22%. His significant cancer risk is 9%, so 3 times greater than background. So he should have a biopsy. Would you do an MRI? And the answer is yes, you should, because he's at high risk. And what do we find? We find that there is atrophy of the gland on the left side. Remember, he's DRE positive on the right side. This is caused by atrophy of the left peripheral zone. You can see some diffuse enhancement in this area. There is no focal lesion. The diffusion image, the high p-value image, and the computed ultra-high image shows no abnormality, nothing on the ADC map. Now, this is atrophy with diffuse hyperemia in the left peripheral zone. This patient does not need a biopsy, despite the fact that the risk calculator says that the significant cancer risk is 9%. So what's the benefit for the patient pathway? One, you've provided an alternative diagnosis for the raised PSA. If a biopsy is done, then an MRI provides a target. On the DRE, you would have targeted the right side. Following the MRI, you would target the left side. There's a potential here again to reduce overdiagnosis and over-treatment. Now, let's talk about the efficacy of the introduction of MRI into the clinical pathway. We can't really conclude yet that MRI benefits the pathway in selecting patients who require radical treatments. We just don't have that data yet. We've got sensitivity, specificity, we can speculate on a number of areas, but we do not have firm data about utilities. There is only one randomized trial looking at MRI versus trust biopsy as the first triage point, and this is this paper that was published in 2015. The interesting thing by just looking at this table is that if you have an MRI first, you go on to receiving the definitive therapy in 1 or 2 steps. Whereas if you have the trust biopsy, if you go down the trust biopsy route, a substantial number of patients require multiple steps before they reach their final diagnosis. So it seems as though the MRI brings efficiencies to the patient pathway. If you want to hear more about this type of approach, then please look at this paper that was published earlier this year. I hope this lecture has been valuable for you in thinking about how you manage your own patients. Bye-bye.